Good evening, everyone. Myself, Dr. Heenal Padalia. I am from Medical Affairs Mankind. It is my pleasure to welcome you all to today's session, which is Care in Crisis. It's an emergency medicine masterclass. We are connected here to today to explore, discuss, and share knowledge on a topic that is of immense importance in the clinical practice, which is titled Acute Breathlessness in General Practice, a comprehensive approach to differential diagnosis and management. As we know, the medical landscape is constantly evolving, and it is of crucial importance for all of us to stay connected, informed, and engaged with the latest developments. So today we have the honor of hearing from expert Dr. Abhilash Tiwari, who is the consulting physician and medical director at Sai Healthcare Hospital. To name few of his achievements, he is a fellow of American College of Physicians and has a certificate program in diabetes from Association of Clinicians of Indian chapter of Royal College of Physicians of Ireland. He is a postgraduate teacher and mentor in the internal medicine at Meditorial MRCP Academy. He holds a postgraduate diploma in cardiology, clinical endocrinology, and diabetes, emergency medical series, advanced diabetes, as well as he is certified in masterclass in hypertension from UK. He also holds a fellowship in infectious diseases from Singapore. He is also a member of Global Association of Physicians of India, member of American College of Physicians, International AIDS Society, RSSDI, as well as Royal College of Physicians of Ireland. He is a director of Science Healthcare, which is a multi-specialty hospital. He is also consulting physician at SRV Mamta Hospital, AIMS Hospital at Dombivli East, Global Health Hospital, as well as Apollo Hospital. He helped thousands of patients during the COVID, and with it was widely recognized by Times of India as hero in their article. To felicitate few awards in his achievement, he scored distinction in emergency medicine and was awarded radio FM on various aspects of internal medicine. He also received felicitations from various social organizations in the field of medicine. So I would like to invite Dr. Abhilash Tiwari to please continue this session forward. Over to you, sir.
Thank you very much. My voice is clear and audible to everyone.
Yes, sir. Yes, please.
Yeah. Thank you very much for this kind introduction and all my backbone of the healthcare doctors. First and foremost, good evening and namaste to all, family physician and the general practitioners. In association with the ACI as well as in collaboration with the Mankind, today we are going to discuss about how to manage a patient with a breathlessness. Why we are trying to choose this emergencies, because 99.9% all the emergency cases, first and foremost, they come and they report to a general practitioner, and you're the backbone of the society. You're the one who looks after the healthcare of the entire society. So as a doctor, I'm trying to make my talk very simple. I'm not going to reproduce from the textbook. I'm going to give you some practical hints that will help you to delineate, to come to a diagnosis, and how can you diagnose your patient as well as treat your patient, and as well as to understand your limitation, that whether I should keep this patient with me, whether I should send this patient. Now, I'm a general practitioner. Let us take into the example. I'm a GP. All of a sudden, one patient comes into my cabin. I'm sitting there and the patient is breathless. Now, in UK, usually, the general practice is a specialty. How will you come to know this patient is serious? So how serious is my patient? This is very important. I know a lot of the general practitioners, senior general practitioners, from single view, an eye view, what we call as an eagle's eye view, can immediately pick up and tell this patient is critical, this patient is serious. So let's try to delineate and make it very clear that how serious is my patient. The patient may not be able to give the history. The breathless patient is often accompanied by the relatives. The patient may not be able to give you the appropriate history. So look at the patient. When the patient, very simple, I'll give you a clue. In case when you talk to the patient and the patient is not able to complete a sentence, it indicates the patient is severely breathless. The patient is not able to complete a complete single sentence. Wherein the cases the patient is breathless with altered consciousness, you have to take it as this is a life-threatening situation, something the patient is about to die. And when there is a saturation less than 92, it is a very serious. Now, I'll tell you, there is one pitfall in this about the saturation, friends. When a patient comes to you, this is an acute medicine, so we are not going to talk about a chronic breathlessness, we are going to talk about acute breathlessness. When a patient comes to you in a clinic, when you apply a pulse oximeter, when you see a saturation is over 92, please don't get carried away. It's okay. What you can do, and just keep on applying the pulse oximeter and ask the patient if they are able to stand up and walk. The moment they try to walk a few steps and the saturation drops, it is an impending sign of a significant cardiorespiratory failure. Mark my word. Even if your saturation is more than 98%, and if you apply a probe and it is showing 98%, you just tell you're feeling breathless, can you get up, can you walk a few steps, and just you keep looking at the probe. If there is a drop in the SpO2, it usually implies the patient is very, very, very serious. So the initial impression of the SpO2 seen on the pulse oximeter can be a misleading. Secondly, those individual who are in shock, who has got an impaired peripheral circulation, the SpO2 may be misleading. So very simple clinical assessment is there. Is this patient able to complete a sentence? Is his level of consciousness okay? Number three, is he looking blue cyanosed? Because if the patient is very anemic, there may not be the cyanosis. And the very simple bedside test I will tell you, look at the respiratory rate. If any respiratory rate is over and above 24, 26, 28, or if the respiratory rate is less than 12, both the extremes implies the patient is critical. Next slide. So, is my patient serious? No, these are certain red flags which the family physician must know. And I try to believe that how you can come to a diagnosis. Now, when the patient comes to you with a very high blood pressure, with a chest pain, when you just take a sphygmomanometer, when you record a blood pressure and the BP is very high and the patient is breathless, you should have an immediate diagnosis. This patient may be a left heart failure or it could be a myocardial infarct. A raised blood pressure with breathlessness. The patient will give you one more history. Doctor, whenever I'm producing the sputum, it is coming like a froth. It is called as a frothy sputum. So the raised blood pressure, frothy sputum, and high blood pressure usually indicates it is a cardiogenic pulmonary edema. The patient is already in left heart failure or myocardial infarction. When you just take a collateral history from the patient, tell you how you were a couple of days ago, then the patient will tell you, doctor, I was having some common cold, I was having a cough, I was having chest pains, and now the patient comes to you with a breathlessness, with a high grade fever and breathlessness. This could be a case of a pneumonia. This is very, very important. Why I just want to tell you this point here, all dear friends. The moment you say the patient has got a pneumonia, the first indication is an urgent antibiotic treatment, not for the bronchitis. Please understand, not for the bronchitis. But like a status asthmaticus, no. The X-ray chest will be normal. The clinical findings will be normal. So simply by putting a stethoscope, this is a stethoscope out here, which I'll be trying to teach you in the subsequent courses, that how to auscultate a patient. The moment you put a stethoscope, number one, the crepitations, rales, increased vocal resonance, bronchial breath sounds. This usually indicates that there is some amount of consolidation in the lung and the patient is supposed to be in a pneumonia. So you have to differentiate between pneumonia and a bronchitis. In a bronchitis, there will be a cough, there will be a fever, but the respiratory finding won't be present. So these individual does not require antibiotic, but those patients with a fever, cough, sputum production, with a positive respiratory finding like crepitations, bronchial breath sound implies this patient has got a pneumonia. This is acutely breathless patient. You have to treat it. Next important thing, never forget to ask about the travel history. Any patient who is bedridden, who is receiving treatment for a cancer, the patient who has come from a long haul flight, presents with your leg swelling, an extremely breathless patient with a normal cardiorespiratory finding. I'm using the word normal cardiorespiratory finding initially. Think of pulmonary embolism. In one of the autopsy study, it was found that a lot of the patients who have died suddenly, they actually had microembolism. And it is often misdiagnosed. It is often not diagnosed because the X-ray will be normal. And typical, the ECG will reveal only non-specific sinus tachycardia, friends. The typical S1, Q3, T3 pattern, what we call in pulmonary embolism, is rarely seen and in extreme stages. You as a family physician, you should see that there is a swelling in the limb. The patient is presenting with a breathless, and now the patient is chest pain, the patient has come, the patient is bedbound. This could be a case of a pulmonary embolism. So we have seen myocardial infarction, when to suspect, we have seen when to suspect a left ventricular failure, when to suspect the pneumonia, and when to suspect the pulmonary embolism. Secondly, the majority of the GP knows the family background of the patient. If there is a past history of bronchial asthma or chronic obstructive airway disease, and these patient comes with severe breathlessness, one diagnosis: acute exacerbation of bronchial asthma, acute exacerbation of COPD. That is very common. Any viral infection or a bacterial infection can trigger significant bronchospasm, and the patient may not be able to speak or utter a single word. I just want to show all of you here about this one. I know majority of the doctors may not be knowing it. This is called as a peak flow meter, friend. Very simple. Your bronchial asthma patient, you should ask to just blow in the peak flow meter. From the peak flow meter, you can come to know how the serious the patient is about the bronchial asthma. The patient is unable to speak a sentence, altered consciousness, use of all the accessory muscles of respirations, and the peak flow is dropping. It implies the patient is quite serious and requires urgent management. Next important thing, this is very common situation in a family practice in GP. One patient goes to one doctor in the morning and he receives some injection, he receives some tablet from a one GP, and all of a sudden, by the time he comes home, or sometimes at the clinic itself, you might have given some injection. A very common practice, an injectable practice, where you give a saline, you put multivitamin, you put an antibiotic, and all of a sudden, when you give this thing, and the patient becomes breathless, with absence of pulse, with a drop in the blood pressure, and you can clearly hear the noise of the breathing, it is anaphylaxis. Please mark my word. Immediately after giving any injection, there is a sudden loss of consciousness, sudden absence of pulse, sudden drop in the blood pressure, and sudden noisy breath. It indicates as an anaphylaxis, friend. And this is the time that you should always, it is hardly 2 or 3 rupees. I believe every family physician should keep adrenaline. I know what the GP is going to do. He's going to give Avil, he's going to give IV Efcorlin, he's going to give dexamethasone, but this is not going to help. By the time the medicine will start its action, the patient will be no more. I have seen so many family doctors, they lost their career because of these, anaphylaxis. So adrenaline should be kept in your chamber, and the ideal dose is 0.5 ml, 1 is to 1000 dilution, intramuscular, not subcutaneous, intramuscular. Immediately you give, and thereafter, whatever you want, you can establish an IV line, you can give a normal saline fast. Don't let this patient die. So first thing you can safely administer is adrenaline whenever you suspect there is a anaphylaxis. One very big misconception among the family doctor is, suppose a patient comes to you who takes a penicillin frequently, and 3-4 times the patient has taken penicillin, so you will be under the impression that the patient is already taking this antibiotic, so there is no chance of anaphylaxis. No, it is the other way around. The patient is already sensitized. That means at any point of time the patient may develop anaphylaxis. Secondly, the bite, the honey stings and all, so that sting in itself can cause a anaphylactic reaction. So you must always have an adrenaline injection in your clinic whenever you practice. Next important thing, when a patient comes to you breathlessness, please understand this type of breathing. On inspiration, usually all the obstructive airway disease, when you expire, you can hear a typical ronchi. You can typically hear a wheeze, which is expiratory, usually implies there is an airway obstruction. But when there is an inspiratory noise, when the patient takes an inspiration and there is a noise, it indicates this is a stridor. Either there is an epiglottitis in the case of a pediatric child group, or that the patient might have inhaled a foreign body. So look at the pattern of breathing, and if there is a noisy breath, the moment the patient takes inspiration, this is not a bronchial asthma, this is a stridor. There is something wrong with the vocal cord, there might be something wrong with the epiglottitis. The patient may have aspirated a foreign body. So you have to differentiate between a stridor, a ronchi, and a wheeze. So never make this mistake: inspiratory noise or the expiratory noise. So this is very important. Any change in the voice with the inspiratory is usually implying it is a stridor, a significant emergency airway obstruction which requires urgent, intervention. Next important thing is the patient is unable to lie down. So what is very important is, when a patient comes to you in your clinic and says, doctor, I'm unable to lie down. So the moment the patient lies down and patient becomes breathless or dyspneic, it is called as an orthopnea. Any breathless patient who is unable to lie down, the breathlessness worsen, it is a typical sign of congestive heart failure. You have to presume this patient is already in heart failure. So unable to lie down, and the patient with an ankle edema, we can clearly see that this patient is in acute heart failure. Next very common presentation for acute breathlessness in acute breathlessness is anemia and the shock. Very, very important. Supposing there is a one patient who is receiving treatment for some non-specific infection, or there is an ongoing blood loss, and suddenly the patient comes to you, look at the patient's face. If the patient looks extremely pale, a severe anemia, acute severe blood loss can present as a severe breathlessness. This is very important point which I want to emphasize here. And as a clinician, remember, GP, because you have a limited resource in your clinic, just understand one word very clearly. You're not going to examine the patient with the clothes on. If the patient is a male or female, आप expose करिए. Just see the chest properly. When the patient's a breathing pattern and you see, you come to know a lot of information. When there is an indrawing of supraclavicular fossa, when you can see the patient is using the accessory muscles of respiration, when you can see the patient is holding the chest in this way, the doctor, I'm unable to breathe, that is a restricted chest movement on the affected side. It usually implies there is a pleurisy, there can be a pneumothorax. Look at the chest expansion when there is, and look at the pattern of breathing. If the patient is using a lot of the abdominal muscle rather than the intercostal muscle, that is the atypical abdominal breathing pattern is there, the patient is having paroxysmal breathing which is happening. So look at the patients very finely. The chest expansion should be equal. The patient should not have a catch while breathing. It usually indicates there could be a pleurisy or there could be a pneumothorax, or even the patient can have a significant, pleural effusion also, which may lead to the breathlessness. Simple test is there, doctor. 3 fingers. I'll teach you in the practical session. Place your 3 fingers within the trachea and try to feel the trachea is centrally or deviated to one side. If the trachea is deviated to one side, that is to indicate there is a mediastinal shift to that side. So simple bedside test, use of the accessory muscles of respiration, the tracheal deviation, the chest expansion, look at the use of the accessory muscles, look at the pattern of breathing, thoraco-abdominal or abdominal-thoracic breathing, and this helps you to understand what can be the likely diagnosis. So we have discussed in short about left ventricular failure. The patient will be having high blood pressure, chest pain, MI. The patient is unable to lie down, that is a congestive heart failure. The patient on expiration, when I'm leaving my air outside, you can hear a whistling noise, typically indicates the patient has got a bronchial asthma or a COPD. And the patient with a recent travel with a leg swelling, presenting with a severe breathlessness, this could be a case of a pulmonary embolism. If a patient comes and tells you, doctor, I'm not well for last 2 to 3 days, I'm having common cold, cough and fever and so on, so I think this could be a case of a pneumonia. The patient is holding the chest, unable to breathe. This could be a pleurisy. This could be a pneumothorax. And if the patient has received any injection recently, or there is a bite, something like that, this could be the case of anaphylaxis and recent blood loss. The patient may come and tell you, doctor, I'm having a lot of vomiting of blood, or I'm passing the blood from my stool in a great amount, and the patient is looking very pale as a breathlessness. So you must have that clinical eye. It does not require any technological advance. You require a very good clinical eye in order to diagnose. So these are the important red flags. Red flags means a GP should not miss this diagnosis in acute breathlessness at any cost. So you have to know, this are very quick, glimpses on how to manage and diagnose the case on a patient presenting with an acute breathlessness. So these are the red flags. I just want you to note down the points. Can we change the slide? So the approach to the cardiac etiology, a very common question a GP asks and the doctor, how I come to know whether this patient has got a cardiac etiology or the respiratory etiology? Remember, the history gives you a lot of clue. Presence of blood pressure, presence of dyslipidemia, presence of smoking, presence of diabetes, and the relation to the position. When the patient says, doctor, after walking a short distance, I feel chest pain or breathlessness or heaviness, and I'm not able to walk. The moment I'm trying to lie down with the position, I become more breathless. High blood pressure. I'm taking these drugs for the blood pressure. I'm taking these medications for diabetes. Always think there could be a cardiac etiology, either myocardial ischemia, ventricular arrhythmia. It could be a heart failure. It could be a congestive heart failure. Next, what is very important thing is from the history, now you're going to examine the patient very clearly. Friend, very simple thing, examine, put your 3 fingers on your radial pulse and look at the pulse. The rate of the pulse is very important and regularity of the pulse. So the rate, regularity, rhythm, this helps you very much. If there is a very high rate, that means the patient is in heart failure. If the pulse is regularly irregular, that means the patient is in atrial fibrillation. If the patient has got a very high bounding pulse, you can feel that the pulse is lifting your finger up. That indicates the patient has got a very high blood pressure. The patient may be having a hyperdynamic circulatory state. The patient may be in a heart failure. Next important thing is the blood pressure. If the BP is very high and low, you can come to know this is very typical cardiac etiology. And the respiratory rate. The RR, as I said you, any RR over and above 26, 28 and less than 16, it usually implies the patient is having a significant respiratory distress. And the jugular venous pressure, it is here, doctor. Can you see this neck part? Simply ask the patient to sit at least arrange the bed at to 45 degree, and you can clearly see the venous distension of the neck, very prominent venous distension of the neck. That is called as a jugular venous pressure, that I'll be taking a separate class how to measure the jugular venous pressure. The raised JVP with the ankle edema usually indicates this patient is in heart failure. Very simple. Those patients who are bedbound, who are already on bed, they're not walking, do not forget to see the sacral edema. You just have to put the trousers down. You have to put a firm pressure on the sacrum and to see, is there any pitting edema? So this is very important. And next, the very important concept is the cardiac auscultation using the stethoscope. Simply, you know the four areas of the heart. Just put your stethoscope, try to understand. When you're using a stethoscope, I'll be trying to teach you this thing. You should be able to differentiate between the first heart sound, second heart sound. Next, you have to see whether there is third heart sound or fourth heart sound. And other than that, are there any murmurs? So the presence of third and fourth heart sound in along with first and second heart sound usually implies the patient is in cardiogenic cause of the breathlessness. Sometimes you are not able to hear any heart sound at all. So it usually implies the chest is hyperinflated. Probably there could be a pericardial effusion. So that is also one thing. And sometimes when the patient says that I feel more breathless while lying down, I want to sit up, you can at times hear the typical precordial rub. So pericardial rub you can typically hear when you're trying to make the patient sit and hear to it. Next important thing is a precordial heave, friends. Look at me. This is your ulnar surface. Just place it on the chest. And at this angle, you just see. If the chest is lifting your hand in this direction, it usually indicates significant pulmonary hypertension. So there is a cardiac etiology. There is a significant pulmonary, what we call as a precordial heave on the left side of the chest. And last but not the least, look for the presence of cyanosis. The bluish discoloration of the tip of nose and the tip of tongue. You have to tell the patient, open your mouth and see the tongue is looking blue. And then you look at the fingers. Remember one take-home message. Whenever there is a central cyanosis, there is a peripheral cyanosis. So do not miss the small clue. It hardly takes 2 minutes. So quick revamp. The history of hypertension, diabetes, or previous cardiac disease. The patient is unable to lie down. The raised jugular venous pressure, the ankle edema, the sacral edema, the pulse, and the high blood pressure, and the presence of third and fourth heart sound usually indicates the patient has got a cardiac etiology for this breathlessness. The most common examples are myocardial infarction, pulmonary embolism, aortic dissection, pericarditis with effusion, left ventricular failure, and pulmonary hypertension. Now, aortic dissection will not present you with a severe breathlessness, though I have mentioned it here, but it is going to present with a severe chest pain. Just keep your both the fingers on the radial artery of both the hands. And when you find a patient with a chest pain and unequal radial pulse, you have to think this could be a aortic dissection in presence of severe hypertension. So this is how you can come to know that this cause of breathlessness is a heart cardiac etiology. Next slide. Now, approach to the respiratory and other etiology. Now, as a GP, I came to know, yes, this is a cardiac one. Then this is the respiratory one. How I come to know with the respiratory? I request every GP to have this peak flow meter in your clinic. It's very simple. When a patient comes to you, vast majority of the family physicians are well aware that patient has got a childhood history or an adulthood history of bronchial asthma, the history of smoking, and typical, all those things like a COPD. The patients may be having birds in their homes and all those things. The patient presenting with a fever, the patient able to produce lot amount of cough, and all these things are attributed to a respiratory cause of, the breathlessness. Remember one thing, the asthma and COPD patient, I'll tell you one very simple clue, do not forget it, how you can diagnose it. We call it as a force expiratory time. Now look, I am taking a deep breath. Just have a look very closely. So it's okay. But the patient with bronchial asthma and COPD, they're going to take the inspiration, but the expiration time will be very prolonged, more than 6 seconds. We call it as a force expiratory time, which is over and above 6 seconds. Look at an example. Just tell the patient to inhale and exhale. If the patient is exhaling more, it is typically indicative and obstructive airway disease, what we call as a forced expiratory time. And one very important thing is you have to place the stethoscope on the trachea to see. This is typically indicating the patient may be in asthma or a COPD. At times, in a very critical state, the patient may not be able to utter a single word. There can be only cyanosis. So the patient with a fever, cough, chest pain usually implies that patient may have a respiratory cause of breathlessness. So you have to differentiate between the asthma and COPD. Now, one very important point I want to tell you, friend, how to differentiate. Both are the obstructive airway disease. The difference is asthma is fully reversible. They immediately respond to bronchodilator. Wherein in the case of COPD is also an obstructive disease, but it is not fully reversible. They are fixed to a certain extent. A history of smoking, always think that patient has got a COPD, and history of allergic disorder presenting with breathlessness, always think of an asthma. Supposing I'll tell you how you can understand asthma. I'm just giving you a clue. Suppose I'm a patient and I'm having a cough. I came to you, you gave me some antibiotic. Now my chest x-ray is normal, it's fine. But now it's already 4 weeks and above, I'm still having dry cough. So this is nothing but my bronchial hyperreactivity, and this is called as a cuff variant bronchial asthma. Yes, it is called as a cuff variant bronchial asthma. And this peak flow diary will help you to delineate and help you to understand whether really I have got a bronchial asthma or not. Because majority of patients, they do not know. When we say asthma, you know only one thing: the patient has got a wheeze and the patient is taking a metered dose inhaler. No, even those patients may present in that way. Asthma is fully reversible, the COPD is not. At times, the patient who has got a long standing bronchial asthma may go into COPD. So, this is something which is very important, friends. Now, you have to examine the respiratory system. Take home message very clearly, friends. Never examine the patient with the shirts and clothes on. Remove the shirt. Look at with the eagle's eye view and look at the pattern of breathing. Is patient looking distressed? Is patient using accessory muscle of breathing? Is patient using the intercostal muscle more or the abdominal muscle more? Is the chest expansion on the both side equal and symmetrical? Look at the trachea, look at the cyanosis, and look at the pursing of lip. This is very important thing. Friends, you see this one. This pattern of breathing, what we call as the pursing of lips, please do not forget, this pursing of lips usually is very typical of COPD. The patient is trying to trap in the air. So this is very important. The pursing of lip during expiration. Look for the cyanosis on the lips and the tongue and the tip of the nose. So small findings is very important. And simply putting a stethoscope on the chest when you hear the musical noise, what we call as a ronchi, what we call it as a wheeze. In the clinical training session when I'm going to take it, I'll be trying to teach you how to differentiate it. So if you hear a wheeze, ronchi, bronchial breath, you should be able to understand. When there is a wheeze and ronchi, it could be bronchial asthma, it could be a COPD. When you are able to hear a bronchial breath sound or a crepitation, this could be a pneumonia. It takes hardly 2 minutes, it's. And when you can hear a crackling noise during the inspiration as well as during the expiration, I use the word, when you hear a crackling noise on the chest during inspiration and expiration, it is typically of pleurisy. It is a pleural rub. So these are the small clues which can, you should never miss out about the respiratory things that can help you out. So with this diagnosis, you can come to know this is a respiratory cause of breathlessness. The patient has traveled and there is a history of leg edema. There could be a pulmonary embolism. So very important. An acutely breathless patient. I am using the word acutely breathless patient where the chest is clear, where the heart is clear, and there is a drop in the saturation. I'm using the word drop in the oxygen saturation. Think as pulmonary embolism. Do not forget it. This is very, very important. Even at GP level also, when you think this is a mild to moderate degree of pulmonary embolism, doctors, believe me, a single dose of heparin 5,000 unit intravenous can save the life of the patient. And equally the pneumothorax. When you see a respiratory cause of a breathlessness, suppose when you open my chest and I'm not able to breathe and I'm holding one chest, and when you do a percussion note, when you do a percussion note, this is how we do the percussion. When you can hear the loud noise on one side of the chest and the patient is breathless and the trachea is deviated to the opposite side, this could be a pneumothorax. So a simple diagnosis will help. Simple needle insertion that we are going to see in the management part can save the life of the patient. And for a GP purpose, a simple pulse oximeter is there. If you don't have pulse oximeter, no worries, doctor. Look at the pulse, blood pressure, respiratory rate. Look for the cyanosis, look for the ankle edema, look for the jugular venous pressure, and look for the pattern of breathing. As I said, you force expiratory time. I'm able to inhale, but I'm taking much longer time to exhale. That is called as a force. It is typical of COPD. It is typical of obstructive airway disease. And when I'm able to produce, when I'm talking to you in a chamber like a patient, when I'm producing lot amount of purulent, mucopurulent cough and all those things, look at the cough. So if it is a purulent, it is usually an infective cause. When it is a frothy, it usually indicates this patient is having pulmonary edema. So small things you have to understand that you should be able to delineate. Supposing A patient who never had any cardiac problem, supposing the patient never had any respiratory problem, all of a sudden patient comes to you with a very markedly breathlessness, and patient says, doctor, I was unwell for 2 days, 3 days, and I had a fever and cough, now I'm extremely breathless. And when you put a stethoscope and auscultate it, and all over the chest you're able to hear a scattered crepitations, I'm using the word scattered crepitations, and a patient, you have to think this could be an ARDS, acute respiratory distress syndrome. It has to be diagnosed. Simple X-ray will tell you a very good amount of information. A scattered crepitations is usually indicating either there's a viral pneumonia or an ARDS. And if I think I believe, strongly believe in India, now that a lot of GPs, the family doctors might be having a pulse oximeter, it hardly comes to 1200, 1300 rupees. So the drop in the saturation, or if not, ask the patient to get up. If patient is able to do, just walk 2 or 3, 4 steps or two, and then you see there's a drop in the saturation. It usually implies an impending respiratory arrest. So simple blood test like an arterial blood gases, that is something which is quite advanced. SpO2 measurement, complete blood count for anemia. A raised WBC count usually indicates infection. A cardiac troponin usually indicates myocardial infarction. There's one more test called as an NT-proBNP, that is N-terminal proBNP, B type of natriuretic peptide, which is usually indicated in the case of a heart failure, and simple 2D echo. I think the patient who is not very critical, at the GP level, you can do simple blood tests, complete blood count, saturation, arterial blood gases, X-ray chest, 2D echo, NT-proBNP and troponin. Simple, you can come to know this patient is cardiac, this patient is respiratory. The next step. So the first aid, I have deliberately made this slide for you, friends. The coming to the golden point, I won't let him die. No GP wants to lose his patient. I believe no GP wants to kill his patient. Everybody wants that his patient survive. So what you can do as a general practitioner, remember, friends, as I said, your clinic should have an atropine and adrenaline in your clinic. At least you can have some portable oxygen facilities. Suppose a patient with an asthma comes to you and you have diagnosed from the history that this is typical bronchial asthma. No worry. Give salbutamol nebulizer, give him oxygen. If the patient has got anaphylactic or some bite or something, single dose of atropine should suffice. It will help the patient to recover. Probably you may not require to refer the patient to the hospital. You can manage it very safely. So all the patients with a bronchial asthma, the bedside peak expiratory flow should be used. It is very cheap and it is lifelong going to serve the purpose. Second important thing, when you think the patient is in edema, there is an ankle edema, the BP is very high, the patient is producing a frothy sputum, this looks like a case of a heart failure. In these circumstances, as a family physician, friends, as I believe every family physician knows how to put an intracath. So once you put a cannula, single dose of furosemide injection with sublingual sorbitate can create a huge miracle. So the diuretics, by the time, because if you're practicing somewhere where the big hospitals are away from your clinic, intravenous Lasix or furosemide 40 milligram, 80 milligram with respect to the blood pressure, and the patient, you're thinking that this could be a myocardial infarction, half the dose or 5 milligram of sublingual sorbitate can save the life of your patient. Equally, chewable aspirin, that is called as a dispersible aspirin or clopidogrel and atorvastatin. When you think that because of technology so fast, I believe a lot of doctors here in Mumbai, they have got an ECG facilities in their clinic. So you can take an ECG, this is MI, okay. By the time you reach to the cardiologist or to your physician, you may die. Friends, believe me, aspirin 300 milligram, loading dose of clopidogrel, 8 tablets, 75 milligram, and atorvastatin 80 milligram. Immediately give to your patient. This will work like a miracle to save the life of the patient till the time patient reaches the hospital. So chewable aspirin, clopidogrel, atorvastatin, oxygen. When you think the patient has got an acute attack of bronchial asthma, what we call it as an acute exacerbation of bronchial asthma or the COPD, friends, intravenous Efcorlin, the steroid, is also one of the first line treatment. So when you think that you can give your patient an Efcorlin, give single dose, Efcorlin, that will help wonder. I have mentioned a molecule called as a captopril. Previously, doctors, you remember there was sublingual depin and nifedipine which was given to reduce the blood pressure in the clinic. A lot of doctors might be aware of it. Now we don't use Depin because there are a lot of studies which has come to know by giving the Depin there is a wide fluctuation in the blood pressure and the majority of the patient suffers either myocardial infarct or stroke, and that's the reason sublingual nifedipine is no longer popular. Oral captopril is an ACE inhibitor. The unique property of this molecule is rapid onset of action and a very short plasma half-life. Suppose my BP is 220 and 120 and you're thinking that it is an hypertensive emergencies. So what you'll do, you're already given me furosemide intravenous. A single dose of 6.25, 12.5 milligram of captopril will work within 10 minutes to reduce the blood pressure. So if the BP comes down, if you give furosemide, the patient may pass urine, and probably you may not have to refer the patient. You can manage your patient very safely. When you suspect, especially those family doctor who are dealing with the critical care medicine, when you suspect this is a pneumothorax, friend, the second intercostal space on the affected side, a 16 to 18 gauze cannula, IV cannula, if you just simply put it, you can hear the gush of the air coming out. It can save the life of a patient suffering from a pneumothorax. And a patient who is breathless, having a purulent sputum, and when you examine the patient, you get a bronchial breath sound, you get crepitations. When even the X-ray can show there is a patch, opacity, the pneumonia, a simple antibiotic can serve the purpose. The question you may ask is, Doctor, why have you mentioned coamoxiclav and azithromycin? All the international bodies, they recommend this combination as the first line. The coamoxiclav, that is amoxicillin clavulanic acid combinations, we have moxikind with us with mankind. So this combination can help, to further prevent. Remember one word, doctor. You as a doctor have to differentiate between the bronchitis and pneumonia. In bronchitis, there may be fever, there may be cough, there may be sputum production. Even in pneumonia, there can be there. But only difference in pneumonia is when you auscultate, you get a crepitation, you get a bronchial breath sound, which you are not going to get in bronchitis. Secondly, a simple X-ray just will tell you there is a patch, there is an opacity, which is not going to see in the case of a bronchitis. So once you have diagnosed that this is a case of a pneumonia, it is imperative that you should start antibiotic immediately. I won't be using the word curve scoring because it is not used in the GP practice. Curve 65 is one of the scoring system where a GP comes to know whether I should treat this pneumonia in my clinic or no. So for your knowledge sake, for the information sake, I just want to tell you, curve 65, if the score is more than 3, that means you must admit this patient to the hospital. If the curve scoring is 1, you can manage this patient very safely with your. So start the antibiotic right. You can judiciously use the use of intravenous efcolin. For asthma patient, you can repeatedly use the salbutamol nebulizer frequently. Please do not use derifylin injections. No, the guidelines even in the ICUs are clear that inhaled nebulizer are much more superior. So salbutamol neb. Suppose if I'm having a bronchial asthma, so repeated every 5 to 10 minutes salbutamol neb along with intravenous efcolin. If my BP is very high, I will give one captopril and you can give me one single dose of intravenous furosemide. So by this method, and if you suspect that this is an unstable angina by sorbitate, or this could be an acute coronary syndrome or myocardial infarct, by giving aspirin, loading dose of clopidogrel, and atorvastatin 80 milligram, you can save the life of the patient at the GP level. And this is what I'm telling you. First aid means what the basic treatment a GP can do in the clinic. I won't let him die. And if there is any bite, anaphylaxis, when you think nothing is working, the pulse BP is not, a single dose of adrenaline can work miraculously. Next slide. So, refer or to manage. Now, this is a question with every GP conference. If there is an improvement with your treatment, you can stabilize your patient and you can call the patient on your OPD basis. You don't have to refer it. But when you think the patient is serious, you can refer it. Always explain in the simple language to your patients and the relative, and always involve the relatives in the joint decision care. A lot of litigations are happening in nowadays in the society. All family physician, one take home message, document everything. The patient came to you. Many times the patient are lost for follow-up. They do not come for follow-up. So mention it on your paper. This patient came to me 2 days ago. He did not come for me for the follow-up. I've advised him admission right now, but the patient is unwilling. Documentation is very, very important. And explain your patient very clearly. See, I feel this is what is there. These are the basic investigation a family physician can do. But it's you have to take a call. Even if the patient obliges or the patient refuses, it's a problem of the patient. You don't have to worry. But what is most important is documentation. Document your finding on the paper, because ultimately when anything goes to the court of law or anything is there, it's what the paper that speaks. So very important whether to keep the patient to you or to refer. So today's talk, friends, we have seen the common red flags a GP should not miss about the cardiac emergencies presenting as a breathlessness, respiratory emergency presenting as a breathlessness, and how basic treatment line can save the life of a patient. I believe that in a days to come, I'm going to take a clinical session, how to examine a heart, how to examine the chest, how to examine a nervous system, how to examine the GIT, so that confidently by proper history and a physical examination, you can come to a nearly accurate diagnosis where you can safely and confidently manage your patient based upon the sound guiding principles. Thank you very much for your kind talk. Next slide.
I think, sir, that we come towards the end of the session. Thank you very much for such an informative and extensive explanation for the acute management of breathlessness in general practice. So there were a few questions that were put forward by our delegates prior to the enrollment of the program. So there are a few questions which I may address, and it would be great if you could address these questions, sir. So
Yeah,
first
please.
one is approach towards patients with ILD presented with acute breathlessness, sir.
Approach to a patient with.
ILD, who is having a symptom of acute breathlessness.
Yes, very good question, doctor. ILD stands for interstitial lung disease. First, you should understand there is no treatment for interstitial lung disease. Antifibrotic agents are there, and all those things are there. By the time when you diagnose these patients, the data says that within next 5 years, the mortality rate will be around 50%. Irrespective, let's come to your question. Interstitial lung disease is not fully curable. It can be manageable. So when an interstitial lung disease patient comes to you with a breathlessness, as a GP, what you should see, is there any new infection in the lung? Is the patient having bronchitis? Is the patient having pneumonia? Treat it accordingly. This is one thing you can do it. Secondly, remember friends, all the patients with a respiratory failure, because interstitial lung disease will lead to the chronic respiratory failure. So all the patients with the respiratory failure are ultimately going to develop right heart failure, what we call it as a cor pulmonale. So again, you see the jugular vein pressure. Whether the breathless patient with an interstitial lung disease comes to me, other than infection, is this patient in heart failure? So these two things is very simple. So by giving, if you think there is an infection behind this interstitial lung disease, you can prescribe the antibiotic. If you think the patient is already having some bronchospasm, you can give intravenous steroids. If you think the patient has developed cor pulmonale, the right heart failure, secondary to the interstitial lung disease, you can give a furosemide diuretics. With the simple step, you can manage it. Yeah.
Thank you, sir. So next one is role of cough syrups in the presence and the preference for the antibiotic in the management of COPD.
See, now to be very honest, the COPD patient will have a persistent cough because they have a chronic bronchitis. The cough is always there. The cornerstone for the management of a patient with a COPD is an inhaled bronchodilators, what we call as a LABA-LAMA combination. So, inhaled bronchodilators are often the cornerstone. When there is a distressing cough, dextromethorphan can be safely prescribed to these patients who have got a cough. But remember, friends, when you think there is a pneumonia or there is an infection or a bronchiectasis where there is an infective part, do not try to suppress the cough. Rather, you try to enhance a drug which can expel the sputum, like mucolytic agents are prescribed. Along with it, the chest physiotherapy is required and the postural drainage. So breathing exercises is a must. Cough suppressant only when you're sure that this is not an infective cough. This is a typical cough of COPD or bronchial asthma. You can use a cough suppressant. Always think of using the proper, inhalation technique for the bronchodilators. And where required, you can use a judicious use of steroid for a very short period of time. And you can definitely prescribe cough syrup, but remember there are two different types, productive cough and a dry cough. For a productive sputum, we usually do not try to suppress this. We have got a mucolytic agents which are available in the market, along with, antibiotic and the chest physiotherapy, we enhance the secretion, mucolytic agents. Whereas in the case where your dry cough is usually not that serious, it can be suppressed. It is very distressing for the patient. So you can use simple dextromethorphan to control or suppress the cough. Yeah.
Thank you very much, sir. So the next question is asthma and COPD. What is the difference and is there a link in between the two conditions?
I have just said you in my talk right now, asthma and COPD both are obstructive airway disease. Understand this thing. And both of the patient will have get acute attack. We call what we call it as an acute exacerbation of asthma and COPD. Both will present a similar way. The difference is asthma is completely reversible. The moment you give a salbutamol 2 or 3 shots with intravenous efcolin, there will be significant improvement. Wherein in the case of COPD, it is a fixed airway obstruction. There is no complete recovery, but it can be managed. So this is a huge difference between the COPD and what is the simple test we do? Spirometry. Every doctors, I think a lot of physicians, they keep it in their clinic. Even I have spirometry. By doing spirometry, we come to know this patient has got a bronchial asthma or this patient has got a COPD. When there is a fixed obstruction that is not going to completely reverse, this is typical of COPD. When it is fully reversible, it is called as a bronchial asthma. At times, a patient can have asthma and COPD overlap, what we call it as asthma COPD overlap syndrome. So this is a huge difference. Sometimes it becomes quite challenging for a doctor to differentiate between, really the patient has got an asthma. I gave you an example. I suffer from, you might have come across the patient where who tells doctor 6 weeks ho gaya aapka dawa leke. From last 6 weeks I'm taking, my cough is not going. And you're telling Boss, everything is normal. Your WBC is normal, X-ray is normal. You're having these patients after an episode of a viral infection continues to have cough. These are also the patients who are called as subsets of cough variant bronchial asthma. In these cases, the spirometry can play a very significant role, and there is one provocative test, what we call as a methacholine challenge test, which helps us to know this patient has got a hyperreactive airway or not. Yeah.
Thank you, sir. So another question which is related to asthma is that what are the role of antihistamines? Like you previously discussed about the other agents that are used. So if you could highlight about the antihistaminic factor, the
Basically,
allergic
honestly
factor.
speaking, yeah. Allergic bronchitis where the eosinophil counts are very high, or the patient who has got a raised IgE level, there the combination of antihistamine with montelukast will definitely benefit these group of patients, but not in all the cases. Not in all the cases.
Okay, thank you very much, sir. So can you just tell in very short or in crux, what are the takeaway practice essentials for the cardiac asthma and a bronchial asthma? If you
See,
can.
very important thing. Friends, I'll tell you. Now, if I'm a GP, let's put it, I'm a GP, I'm trying to act as a GP, and there's a patient coming to me. When I look at the patient, the way the patient come inside my cabin, the time the examination starts. So as a doctor, I have to first see how serious this patient is the patient very serious? I am able to manage it. You have to differentiate. Second important thing, you have to differentiate, as I said you, whether this is a cardiac breathlessness or whether this is a respiratory breathlessness. If it is a cardiac breathlessness, by giving a simple aspirin, statins, intravenous furosemide, you can stabilize the patient. If the patient has got a respiratory breathlessness, by giving a nebulizer, like salbutamol nebulizer, intravenous efcolin. If you think a pneumonia is there, you can prescribe the antibiotic. You can create a huge impact, because I know in India, vast majority patients are unwilling to go to the physicians, and at times it is beyond their capacity. My today's talk, purpose of this today's talk is to enlighten you, encourage you to understand as a clinician that you can confidently tell this is a heart problem, this is a respiratory problem, this is I'm going to manage, this is a first line treatment, whatever it is, I won't let you die. The reason is what? That let the patient take a call. Now you have to go to a physician and you have to tell all these things. But as a GP, you should be confidently able to manage this patient very safely. So this is something which was a take home message, because a huge chapter, acute breathlessness. So it is a small, a type of an enlightenment which I'm trying to touch upon, that a GP should not miss the red flags. Yeah. Suppose like there is a limb edema and the patient will come, doctor, मैं 3 दिन से train में हूँ, I'm coming, I'm not able to walk and all, and I'm having breathless. And you can say, oh, this could be a mild embolism. So simple heparin, one single heparin, hardly it is costing, I think, 10 or 15 rupees, one vial which is coming. So simple heparin can save the life of the patient. So don't miss the diagnosis.
Surely. Thank you very much for telling it in very short, I think. And sir, last but not the least, ARDS, which is like mostly we see in the in-hospital setting, but in Indian outpatient settings, like if you could help us in throwing some light on the timely recognition and the diagnostic strategy, and most importantly, the referral part, if you could highlight that, sir.
Now, the first thing, how will you recognize a patient has gone in ARDS? The first thing, as a GP, I don't have anything. The patient comes to me. When a patient comes to you and says, Doctor, I was apparently all right 2 or 3 days ago or 4 days ago, I had some viral prodrome like running nose or something. I became much breathless. And you can see that I am looking tachypnic. There is a cyanosis. The saturation probe of the O2 is typically showing the oxygen level less than 90. My RR is more than 28 beats per minute, 28 per minute. And when I'm using the stethoscope, please understand this is the stethoscope which I'll be trying to take the class when the time will permit, that how to auscultate a patient. When you auscultate a chest, you will find a diffuse scattered crepitations all over the chest. Diffuse scattered crepitation with a breathless patient all over the chest usually implies the patient, and when you try to give an oxygen, the patient oxygen may not correct immediately. This usually indicates from a general practitioner perspective the patient is in acute respiratory distress syndrome. And I believe X-ray is available everywhere. You just send the patient for an X-ray. A scattered opacity, multiple white patches all over the lung is the first sign the patient has gone in ARDS. Whatever is the reason, sepsis, infection, virus, whatever is the reason, this patient is critical. So what you can do, you can start the oxygen. You can give Efcorlin, you can start with an antibiotic, and meanwhile, while you take an X-ray, you can accompany the patient to the hospital. You won't let this patient die. And very important, friend, once you have diagnosed it as an ARDS, remember one thing: ask the patient to be in a prone position. Do not lie down. पीठ की तरफ सोना नहीं है, छाती के बल सोना है. So that more oxygen should reach to your lung. Remember this very take-home message. When you think this is an ARDS and the patient is breathless, prone ventilation, even when we put the patient on ventilator in the ICU, we give a prone ventilation. So a simple step can do it. So in nutshell, a scattered crepitations with a white lung field in otherwise healthy subject who was apparently all right 2 or 3 days ago with markedly breathless, markedly hypoxic, usually indicates the patient has gone into ARDS. And once the patient reaches the hospital, then we categorize it as a mild degree of ARDS, moderate degree of ARDS, severe degree of ARDS. The patient requires ventilator, prone ventilations, or ECMO, and then we decide. But from the GP perspective, do not miss this diagnosis. Is that clear?
Thank you very much, sir. So I would now like to request Mr. Ashish Singh to please pitch in.
Hello. Very good evening to all of you. And first of all, on behalf of Life Mankind Division, I would like to render my thanks to Dr. Abhilash Tiwari. Thank you very much, sir. It was a phenomenal session. I would say, though the slides may be very less number of slides, but very, very descriptive. The way you actually have elaborated each and every step that our physicians across the country has to take in order to handle and manage the patients with acute breathlessness. It's phenomenal. I don't think anybody can actually elaborate in such a lucid term. I'm sure that all the delegates who have joined today must have been benefited beyond imagination. And I'm sure the insights which has been shared, the guidelines, the recommendations, the suggestions which has been shared by you must be helping them in their clinical practice to take care of their patients. So once again, thank you very much, sir. And also, I would like to render my thanks to all the delegates who have joined in the evening. You have actually spent almost an hour remaining completely associated, glued with the screen, and then listening to this talk from Dr. Abhilash Tiwari. Thank you very much, all of you. I still would be sincerely requesting the feedback from all of you. If you have joined from your mobile, please share your feedback in the query section itself. And if you have joined with our team members, please give your feedback to them. They can actually put it over there. Your feedback definitely would help us improve further in the future. You can also communicate in this section of queries. You can put forth over there what are the kind of topics you would like to actually have lectures in the future. What are those topics which you think that these would be very, very much important for, and you would like to get some guidance from doctors like Dr. Tiwari. So please do give your feedback over there. Thank you very much once again, and looking forward for more such kind of a program and having your presence.
Thank you, Mankind and entire doctor fraternity, for giving me this opportunity. And we'll try our level best to make the medical knowledge more practicable so that every general practitioner of this country should benefit. And in turn, we should benefit our own people, our own citizens. Thank you very much.
Thank you, Doctor. Technical support, Mr. Prashant. We can disconnect the audience link now.